All right, I'm going to pass you the ball. Okay. So we're now recording live. Today's Wednesday, June 11th, 2014. It's our 42nd session. I'm Karen Kalishman, the project manager for Project Echo LA. This is the Adult Psychiatry Knowledge Network. And just a couple of housekeeping. You all know the rules, but two important things that I do have to say each time is HIPAA compliance. Please, when you're describing any of your patient cases or talking about patients, in order to be compliant, we need to not mention any patient identifiers. And secondly, disclaimer, Project Echo LA case consultations do not create or otherwise establish a provider-patient relationship between any clinician and any patient whose case is being presented in a Project Echo LA setting. And I think that just about does it. So I'm going to turn the ball over to Dr. Bonds, our specialist mentor. And we do have a couple of cases today, so hopefully we can get started with those. I don't know if we have any follow-ups. We'll see.
Okay.
Excuse me, I'm sorry, Dr. Bonds, Karen. This is Dr. Johnson and our team here. We are not able to log in. For some reason, the link in your web page is not allowing us to get on to the internet. It says that the page cannot be displayed. So I don't know.
Did you use the email that I sent today or the yesterday's one?
The one today at 11:21 a.m.
Okay, let me go back and see if I can resend you the link.
Okay.
So you called on the, in other words, you called on the phone?
Yes, we're calling in on the phone.
But you can't see anything, right?
And while Karen does that, let me just ask if anyone in the group has, looks like we have a lot of familiar faces and friends, so I won't do introductions this time, no visitors. Anyone have a case they want to present, a spontaneous case, or are there any follow-ups on previous cases that we've discussed? Keep in mind that one of the benefits of the ECHO is that you're able to take this information out to your site and then hopefully distribute it or apply it and bring back the results to us.
Yes, I do have a follow-up actually on the patient that we presented at last ECHO session. She was a 53-year-old Armenian-American woman, and the information was given to the medical provider who met with the patient shortly thereafter and found out that the Oh, great, thank you. Everything turned out that the patient had not been taking her medication as prescribed, and so the provider was able to counsel her again on how to take the medication, get the support of family members to help her to take it, and so she was starting to feel better at the following visit when I saw her. So thank you very much.
Oh, that's good. Do you remember what intervention was recommended during the echo? Because I can't, off the top of my head, recall that case.
She had post-traumatic stress disorder, and so you had recommended the SSRIs and the possibility of titrating up, as well as a particular pattern of balancing the SSRIs with other medication that she had had. And it turned out that the Paxil that she had been taking, she was only taking it, quote, as needed, rather than on a daily basis. So the provider got her restarted on that, and we're starting to see some small improvement.
Oh, good. So the change was just to talk with her about medication, and it turns out we didn't have to go up because she hadn't gotten out of the gate fully yet. That's great.
Right. So it was great. Thank you.
Thank you. Any other follow-ups or people that want to be in the queue for cases today? Okay, well.
This is Monica. I have a spontaneous case, just a quick question, whenever you have time.
Okay. What you might consider doing if you're Monica, mute yourself. We might have to have you type in the question because it's going to be hard for us to hear because there's feedback. I think it's because of the location. It's just
okay.
So
okay, for sure, I'll do that.
For the day. Dr. Johnson, I believe that both of them are from your group. Let's start with this 48-year-old Hispanic gentleman with memory problems.
All righty, that is our case, and we actually do have a guest or a new attendee here from Chat Care. Dr. Paul Gay-Loomis is here with us, and he is our physician who does the outreach services for our homeless programs and at various shelters and community residences. And he's the one who gave me this case to submit, to present. So he's here, and he can actually get some info. We are now starting to be able to log in, so we'll be able to watch the case that we have.
So, Allison, you got the new invitation with the new link, right?
Yes, we got it, and it's looking like we're going to be able to log in.
Okay.
Hey, Dr. Bond, nice to meet you.
Nice to virtual meet you, too. And it looks like you gave us a wham dinger of a case to start out with, but we'll do our best to cover it. Whenever you're ready, Dr. Johnson, we'll go ahead and start.
Okay. Well, I'm still trying to get logged in. I apologize. Paul, did you want to tell them or want me to present? Okay, I'm sorry. It's still not letting me get in for just another 30 seconds. I can't talk and type at the same time, so I apologize.
That's okay.
I'm typing the wrong email.
Well, while you're doing that, I'm going to type up in the chat box for everyone a resource that I think relates to this case that was sort of requested, and people can, at their leisure, possibly go and explore. It's the link to the LA County Mental Health Courts, where a lot of information about conservatorships is posted, because I think that's where this discussion is going to head.
Okay, County Mental Health Court, that's good.
Wow, it found us. Okay, let's see if hey, we're there, finally. Okay.
Yeah, I can see your...
We're still listed as calling user 4, that's our voice, but we should be visible right about now. There we are. So there's Dr. Paul off to the side of me. I'll scoot in here a little bit. Kim and Deanna are here off screen. So here's the presentation. He's a 48-year-old Latino male. He has memory impairment. He had a history of cerebrovascular disease, lower extremity weakness, homelessness, and polysubstance abuse and dependence. He comes to sessions with a caregiver who is also states she is the payee for this patient's benefits, his public benefits. The caregiver is very overwhelmed by being the patient's only support. He's non-adherent with all recommendations. He misses most medical and psych appointments. He did not get lab work done. He doesn't take his meds consistently. And he does continue to abuse drugs and alcohol. She says that he's been in and out of the hospital for strokes and brain hemorrhage in the last 6 months. And he did have housing for a brief time, but he left it. He walked away from his housing to spend the money on drugs and alcohol. She's the only one to help him when he's in crisis. And the patient's family refuses to be involved. The patient is currently homeless, sleeping in the caregiver's car. He is verbally abusive to her, which Dr. Paul observed in his office visit. And Dr. Paul has observed that he's unable to care for his own mental health and medical needs. And this is likely due to the brain injury and also the consistent substance use. He doesn't want to accept housing help, substance abuse help, is not compliant. So what legal actions do we need to take? Our questions were, what recommendations should we make to the caregiver for her relationship with the patient? And is her level of involvement appropriate? And the second question is, what resources are known for adults with traumatic brain injury and cognitive deficits? Regional Center doesn't manage these patients. The third one was, what would the steps be to establish a need for conservatorship, and what are the criteria that would have to be met? So here's, and interestingly enough, after presenting this one, there are a couple of patients that have come to our notice that fit similar criteria. So this is going to be helpful for us in general to get educated on this.
Okay.
So, I'll mute up.
So let's start with probably the biggest challenge. In terms of safety concerns, which is what I look at first, you mentioned that there's been some domestic or some violence between this gentleman and the caregiver. Is she feeling that she's at continued risk, or has he been more than verbally abusive? Because it seems like there's arguments, but I wonder, has it escalated beyond that?
Well, I should say first that Allison did an amazing job of presenting that case. That covered all the bases that concerned me. So that was great. Now, let me add just one or two things, which are that I only see these people very intermittently. I think I've seen them twice this month, but that was the first time I've seen them for 6 or 8 months. He goes in and out of our care. And often it's just this caregiver person who brings him in. I've talked to her about this arguing they have, because they're constantly bickering in front of me. And it appears, okay, I've said to her, well, why are you still his payee? And she kind of says she's the only one who will help him. He ends up on the street, and he comes to her house, and she can't turn him away. And she even used the word herself, codependent. This is the word she used herself. And I said, and then she told me the most recent time I saw her last week, or earlier this week, she came on Monday, she said that he's hit her and he's broken her car windows. Like he's got very, a lot of issues, impulse control and anger and, just being totally out of control. But I said to her, I said, well, have you considered getting a restraining order against him? And she said, no. And I said, why? She said, well, you have to have a police report to do that. And I said, well, and she said she's never filed a police report. And I was, for her safety, I was encouraging her to, do these things. But I think he was an ex-boyfriend of hers, and I think the relationship is very complicated, and it's not as simple as her, taking those steps. She has some, gain of some kind. I don't know if it's emotional or what in that relationship, but it's not as straightforward as her contacting the police, and so she's not really willing to do that as far as I've been able to tell. And she insists on, she keeps saying to me, she's very emotional and doesn't feel in control. But I said to her, why are you still his payee? And she, she always brings this up. And then she says she doesn't want to be his payee, and she's going to go, sign off, but then she never does. So, it's this kind of real dysfunctional type of behavior.
Yes, I would agree. And based on the information presented, it sounds like she may be afraid. And I would really work with her around her desire to help him and to focus on that. And then to say that until you make some decisions that may be tough decisions, you may not be able to get better, because I think codependency is an overused term, and it's kind of a lay term, but basically she's enabling. She's allowing him to continue with some of his erratic and undesirable behavior because she's facilitating it by either providing him with money, being his payee, being involved, letting him sleep in the car. All of those things kind of point to she's helping him maintain a certain level of stability that prevents him from needing additional care because she's sort of providing it, but yet he needs more than what she can give. So I don't know the firm answer to that except for to tell her that she has to set some limits. And until she's willing and able to do that, it might be tough for anybody else to intervene. So in terms of is her behavior or her level of involvement appropriate, which is the first question that I see, I would say that no, she's a bit over-involved and she may not be able to be as objective as someone who, say, were a court-appointed payee or if the courts or whoever the source of the funding is knows how they're being spent, not necessarily for his benefit, they probably wouldn't be too happy about that, especially if they're being used to purchase drugs.
Oh, I missed that last sentence. What did you just say? That was helpful. That last sentence you just said?
That if there is any agency that is managing the funds, one that distributes them to her, if they knew that they're being used for something other than food, clothing, shelter, like if he's getting the funds and then he's spending them on drugs, that could be a risk for him to possibly lose that funding. So I think that she needs to know that if she's the person who's responsible for it and they're not being used appropriately, then that's a problem. One of the considerations might be that instead of giving him cash, she could give him gift cards, for example, translate the cash into, say, gift cards for either food at a grocery store, or there might be certain food establishments that he's frequented. Sometimes you can go to a place like Subway or Taco Bell or whatever the places are that you might purchase food, or even to the grocery store and say, look, you know, I'm going to give you these so that you can spend the money at a place where you need to get sustenance from, but not to give you cash, because that seems that it's problematic if she's just giving him a check and signing over, because a payee is supposed to be a person who ensures that the funds get spent appropriately. So that's a job that as long as she's taken it on, she's enabling and she's possibly colluding with him if he's spending it in a different way. I'm not the most familiar with that system, but if there's a social worker who works with your clinic, they might know more than I do about her responsibilities as payee, but I would really focus on, in order for you to help him, you're going to have to set some limits and not just enable his behavior. So a second consideration, sorry, was someone going to say something?
I mean, the only thing is that I agree. That's very helpful, everything you just said. And I presented that to her last time. I said, he probably is going to have to, hit bottom if he hasn't already, hit it before he takes any responsibility, if he's capable of it, I guess. But in any case, she says her answer to that, because I said, I kind of said it, but not in such well-put terms as you just did. But I said, as long as you're taking his money for him, he's probably not going to, that's a support for him. And she just basically said he hits bottom and then he comes to her, basically. So, it's this weird dysfunctional cycle. But I like the way you put it, and I have to present that to her again. I mean, I think, if she's feeling overwhelmed, I think what I probably should insist upon, or, as best as I can, is that she's not his payee anymore. Is the only answer to me, in terms of her involvement, but I don't know what you think about that.
It may seem extreme, but to a degree what she's doing now with him, because he is kind of dependent, that she's parenting, and she can make the decision to stop that by simply saying the next time that he comes to her or he's looking for his check to say, I can't do this for you anymore because I see you hurting yourself and I think you're at some risk of injury, more serious illness, or death, and I don't want to participate and just be a bystander for that. And so to refer back to the agency that she's picking up the money from or that she's getting the check from, to notify them that I want to exit myself from this situation, can you have a public payee assigned? One of the conversations that we need to have about this particular person is grave disability. You mentioned in the second clinical question, and I want to focus our conversation to at least make sure we cover those, that he has traumatic brain injury and cognitive deficits. So technically speaking, it may be that he has more of a neurologic and neurorehabilitative injury than as opposed to a psychiatric injury. So I would wonder about, is there something that's happening psychiatric? As a psychiatrist, TBI is not a diagnosis that I routinely make, but I might make a diagnosis of something like impulse control disorder or mania secondary to a traumatic head injury, wondering about this person's having possibly depression. So I would look for treatable psychiatric conditions that are secondary to the TBI, because I don't have a treatment as a psychiatrist for the TBI per se. I do know of some resources. The biggest locally, as you mentioned, Regional Center doesn't deal with adults who had their injury after the age of 18. Even though he may have a functional IQ that's below normal or average, I would say that at this point he falls more into the neuro rehab fold, and a place where people can get help. The biggest resource for the county is Rancho Los Amigos, and they do have a website that I visited briefly. I didn't put the link up, but I can. They have resources for folks who have traumatic brain injury for recovery. I think they have the different levels of response, everything from people who are essentially neurovegetative and need total assistance to those who may have just moderate agitation or have minimal levels of assistance. And to some degree, there are various levels of support groups that might be available to a person if you link to that resource. It's the county rehab hospital. They deal a lot with folks who've had brain injuries. So I just posted in the chat box for everyone the link to the Rancho Los Amigos information. But the conversation psychiatrically goes down to grave disability, which is the question that we always ask when we're considering conservatorship, because as you know, in terms of involuntary treatment, there are three variations. One is danger to self, danger to others, and then grave disability. And danger to self and others really doesn't qualify someone for long-term care, because those are generally thought to be sort of short-term, limited problems that we can intervene with, say, during an inpatient hospitalization. Meanwhile, grave disability is thought to be more pervasive, more of a state as opposed to just a temporary condition that someone's in. It's more of a trait, I guess, grave disability. Because of his traumatic brain injury and his substance abuse, he might qualify, but honestly, in order for him to really be on a psychiatric conservatorship, there would have to be an underlying psychiatric diagnosis. Substance abuse is excluded, so if a person is drinking heavily or using drugs, you cannot enter that as evidence that this person is gravely disabled, because that's a different treatment system. What you could argue, though, if he does, say, have something like impulse control disorder where he can't manage his funds, or if he's manic and doesn't have good judgment, or even psychotic, then you could build an argument that as a result of his psychiatric illness, he's unable to procure food, clothing, and shelter, which are the three categories of grave disability. It seems like shelter is a problem because he's living in her car. She would have to say, I wouldn't allow you to live in my car any longer. Then he becomes homeless, and if he doesn't have wherewithal to live as a street person successfully, then he essentially becomes more gravely disabled. He does have money right now, and so that's another category which we would look at for establishing grounds for conservatorship. If he has funds and he can buy food, clothing, and shelter, like if he has enough money to pay for a hotel and he can actually execute those transactions, then he doesn't qualify for grave disability. So the best bet is for her to separate herself from his money and to prevent him from having a place to stay. And then when he goes to an emergency room, or when she contacts the authorities and outlines where he is in terms of his functional status, look, he doesn't really have the money or the ability to manage his money. I'm his payee, so that's kind of established. Doesn't have a place to stay. He's staying in my car, which isn't considered a healthy place or a suitable place for someone to live. And the last thing, in terms of clothing, well, he might have that, but it might be the only one that he would have. But proceeding towards a conservatorship is a difficult process. In LA County, the vast majority, I would say probably 95% or more, are initiated in a hospital setting. And it's not even everybody who goes to the hospital who's gravely disabled at time of discharge gets an application for conservatorship. It tends to, because of limited resources, be reserved for the most seriously ill, who generally have been in and out of the hospital several times. Maybe they've had a few incarcerations. These are people who are sort of the recidivists of the mental health system, and I don't think he's there yet. There is an avenue to pursue outpatient conservatorship. One of the links that I put up earlier in the chat that people can possibly visit is to the LA County Public Guardian's Office, and you can contact them. You can just do a search if you don't see the link, or the Los Angeles County Public Guardian. They're the folks who initiate the process if the concerned community member, family member, friend calls up and says, hey, this person isn't in a hospital, but I have grounds to believe that they possibly would benefit from a conservatorship. You point out that they're already on a fiduciary payeeship and say that you'd like to initiate a plan for conservatorship. Typically, as an outpatient, it's hard to do that unless the person has a private attorney that they pursue it with. But the public guardian's office can tell you how to go about it with that. There are a variety of different powers that are defined by conservatorship, everything from being able to put the person in a locked facility, being able to medicate against their will. I don't know that she would want to take that on, but I think in terms of her authority to notify the public guardian's office, that would be a place where she would sort of protect herself and say, hey, I've done the best I can for this person. Let me pause there and see if I've either answered or raised questions for you all.
I do have a...
Go ahead.
Okay, yeah, very helpful. Thank you so much. That's a great resource, the LA County Public Guardian, and I really like the, you know, that gives me some real practical steps to talk to the caregiver about. Now, the LA County Public Guardian, is that a resource that I can use myself to initiate the conservatorship, or is that, like, would that more apply to her?
It could be either. I think providers are generally probably going to have more leverage because they're going to listen. I think a lot of concerned family and community members might call up and not have the knowledge that you would be able to explain it in medical terms. I think what they're going to really focus on, though, because they tend to look at conservatorship as being for those who are psychiatrically disabled. So if you don't already have a formal psychiatric diagnosis to sort of supplement the TBI, that's where you might want to put some of your energy before contacting them. But I think on the website it says that anybody can contact the LA County Public Guardian's office, the regional office, to say, hey, this is where the patient is located, and then request a conservatorship evaluation.
Now, are you saying that the conservatorship is strictly for people with mental health issues? What about like somebody like, I mean, I believe he has both, and I'm not sure which is the chicken and which is the egg, but he has been prescribed antipsychotics, and she brings me in these prescriptions and these bottles, and he just doesn't take them. You know, he just absolutely refuses to take any treatment. So that is, you know, thrown into this whole mess is the fact that he's not really seeking the help. So, you know, this is definitely, you know, like the resources about Rancho Los Amigos, you know, he's not, it doesn't look like he's going to go to these appointments that we make for him, even if we do. So I think in my mind, what has to happen is somebody has to take responsibility, you know, and there has to be a conservator. But I guess that's the question, is that, you know, even I can try to track down what diagnoses have been made, and I certainly think he has an impulse control disorder, but, you know, that's partly maybe because his frontal lobe is damaged from the strokes or the brain hemorrhage. You know what I mean? It's a complex. And well, I should know too. I did a mini mental status on him. I brought it in today. I put it in the chart. But interestingly enough, I've known him for a couple of years. And when I did a mini mental status about 2 years ago, it was like 27 or something. I mean, I was shocked at how normal it was, because he seemed pretty out of it then. But today was, yesterday or Monday or whatever it was 16 out of 30. So it's really declined his, you know, some of this depends on substance abuse and all this too, but, you know, he really was, his memory certainly declined, and that, you know, I'm trying to get a little objective measures, but.
Well, I think that the system that I'm aware of is the LPS conservatorship system. There may well be others, but I guess from a mental health perspective, it sounds like he would qualify if he's been prescribed antipsychotics. And based on some of the behavior that I'm hearing, I think he would be someone who could at least be evaluated within that system. The two groups that are kind of outside of it are those who have dementia, because that's a separate conservation process. The same thing is true with people who have substance abuse problems. Those are kind of excluded because, quite honestly, I think the system would just be overwhelmed. But at the website that I sent out about the Public Guardian's Office, it's for those folks who are unable to manage themselves, unable to provide for their finances, and generally it's a process that's initiated because the person suffers from some psychiatric illness, and typically they've been committed to a psychiatric facility. So a start might be that the next time that he has an escalation, she may set a firm line in the sand to say, look, I'm not going to do this. I'm not going to facilitate. You're mismanaging your funds or doing whatever it is that he's doing that's causing problems. But to say, you know, if he escalates and she gets threatened, then she would call 911. The emergency services would roll out. She would give them this story. That's how it could play out. I mean, a lot of gaps in the way because he's an outpatient. Again, outpatient conservatorship exists, but it's been sort of like this elusive unicorn that nobody's really been able to grasp onto. I mean, other places like New York State have Kendra's law, but here in LA we don't.
The other thing I did is after I made this talk to Allison about this, I did spend an hour on hold on the phone and finally got in touch with Adult Protective Services, LA County, and I did have a good, because that was suggested by either Grace or you, and I did end up finding a good caseworker who faxed me this paperwork, which was a capacity declaration, and he said I write a cover letter and fill this out, which I've been, you know, kind of working on. And then he said he might be able to go do a visit. I mean, I don't know, do you think that one path is a better path to follow, like your suggestion of the LA County Guardian, or is this the same thing we're talking about?
I think they may be connected but separate. The Adult Protective Services is more focused on older adults, and since he's only 48, I don't know how interested they'll be. He does fall into a vulnerable adults category, though. I guess I'm not able to comment too much on the capacity and where that will lead you. I get the sense that's probably more for managing someone's money and not so much for treatment that he would get if he were in the LPS system. The last thing is that he's apparently being seen, I think it was this person at Pacific Clinics, is that right?
Exactly, and they know him well. They know him well, and I had a long talk with the manager at the Pacific Clinics on Hurlbut Street, and she was very nice, and she was very familiar with this case, and she actually suggested, she was one of the people who suggested I contact Adult Protection, you know, as a, and that was one of the reasons I came that way. But you know, they're in the same boat that I'm in with him. They knew the same history with the dysfunctional relationship with the caregiver, and they, you know, they don't see him. I think he hasn't gone there for a year or something. You know, everyone's closing his case. You know, so it's this kind of really erratic stuff that makes it so hard to get a hold on.
Yeah, I mean, I would comment earlier that this is an advanced case, and certainly most primary care groups would feel like this is a specialty intervention that needs to happen. And so Pacific Clinics, if they haven't stepped up to the plate, hopefully they haven't just absolved themselves and washed their hands saying he's treatment non-adherent, which often does happen, unfortunately, with community mental health centers. But if there's someone there that you can partner with to say, look, I don't know if your docs even know him. It sounds like he doesn't keep appointments, but he does keep them with me. I'll provide you with whatever information you need and help fill out some of the forms, because that's a rarity, but it's something that I think to pursue through the Public Guardian's office. I'm going to pause and maybe at this point move on to our next case unless there's other burning questions that you have.
I really appreciate this. Very helpful.
Okay.
Can you hear me, Dr. Bond?
I can.
I just have a really quick question. What is that designation when someone is not considered mentally stable and the police come and they put them in the hospital temporarily?
A 5150.
5150, yes. Has this gentleman ever been put into hospital for that?
You know what? I get the impression he has, but
revolving door.
It's never. I don't think that a conservatorship process has ever been initiated while he's in hospital. I think he just gets discharged back on the street. That's my impression. Yeah,
usually if he gets admitted to hospital, as soon as he says he's not suicidal or homicidal, and if he says he has a place to go and a check, then he'd be out. I think it would require teams sort of advocating around him and talking to the hospital to say just how difficult he's been. And then even still, I don't want to give a false impression. It's a pretty high bar. I mean, he's standing in line behind the folks who've had 8 admissions in the past calendar year and who are, you know, defecating in front of police stations. That's, you know, those are the folks who tend to, in hospital, wind up on conservatorships. So it won't be easy, but I definitely try to do whatever you can for him. I know there was another case from Dr. Johnson's group, 26-year-old woman, and we move on to this one.
Okay, sure. This is a patient whom I've been working with for about 3 sessions now. It'll be our 4th session, our next visit. She has what appears to me upon first look clear evidence of ADHD, though she states she was never evaluated or received accommodations as a child. She describes it, I feel like I'm all over the place. And she says, now I'm not hearing voices, mind you, but it feels like there are 30,000 Teresas in my head. Oh, shoot, crumb. Everyone with a different idea, and they all want my attention all at once. And she's saying she procrastinates, especially on things that may have unpleasant results or may be difficult to go through. She can't attend to any task for more than 3 or 5 minutes. She avoids looking at calendars. She said in session, I have to apologize because sometimes I will look like I'm listening to you and I'm a million miles away, so if I ask you to repeat something, it's not your fault. I don't think you're boring, I just can't listen to you. And she feels very flooded with thoughts, and she will lose track while she's driving and miss exits or get off at the wrong exit. It started severely affecting her day-to-day life. She forgets her keys in the house and locks herself out of the house with her kids and outside. She's locked her children in the car. And she has significant anxiety as well. She is very afraid of her husband going even to a restaurant that's around the corner where she could reach him by phone or walk to the restaurant. And I see that as secondary to the distractibility. I've observed fidgeting, a lot of pressured speech. She talks like about a mile a minute. She's worrying that she's forgotten something or has been distracted. But her narrative is good. She is not tangential. She is not as random as you might expect from someone with mania or manic bipolar. Her memory is good. No hallucinations or delusions. No suicidal ideation. And in the most recent visit, she stated that at work she is able to focus and concentrate better than anywhere else. And she works at a place that prepares meals for families that people then purchase them and take them home. And when we explored why this is so, she said it's because the task is laid out there in front of me on the table. It's the only thing that there is to do, and my boss is there in the room with me. And I thought to myself, great, we can't all be in 6th grade with a teacher watching over our shoulder anymore. So, our question is, she's asking for medication with anxiety, and we were wondering which we should start with given this strong ADHD component. And I also want to be leery just in case it is something to do with bipolar disorder. Mindful of the recommendation that you made last time, I asked about her fatigue, and she does say she is fatigued due to insufficient sleep, which is why, again, I'm tending ADHD, maybe not, manic bipolar disorder. So where do you think we should go with her as far as medication? And if it's something that is going to need Adderall, then we can refer her out. But what should we do with this poor lady?
First of all, 3 gold stars for asking about fatigue and sleep. It's nice to that y'all are getting there and applying some of the tools. So if she's not feeling tired after she doesn't sleep, that would be mania. This doesn't sound like that, but it did raise a red flag for some other things based on some of the symptoms, and we'll go through those in a moment. But it raised the question for me, does this woman have a trauma history at all that you're aware of?
Not that I am aware of. If it is, it would be like series of small traumas. Her parents were not terribly attentive, but there is no significant major trauma or repeated traumas in her life. She doesn't have a history of abuse, neglect, or sexual abuse.
Okay,
no.
That's good to know. Because what this sounds like, especially with the driving along, missing exits, and the, hundreds of voices of her name in her head, and her inattentiveness, while it sounds like ADHD, it also sounds a lot like dissociation. And those sorts of complaints I hear more from folks who have dissociative disorders than I do from ADHD. Now, a lot of folks don't come in complaining that, gee, I think I'm dissociating, because first of all, they're not familiar with the language, and secondly, because it's just not something that medications are targeted for. So she's saying that it's anxiety, but to me it sounds like it's really something else. She's having trouble concentrating. Just to go back about how she's able to operate in a structured setting, we see that a lot. That's one of the reasons why when someone goes from, say, being a line staff worker to being a manager, you know, at the tender age of 45 or 50, it might be the first time they really manifest ADHD symptoms, because before that, maybe what they were doing was very rote, very manualized. It's also why sometimes students find that they have trouble when they move from, say, high school, where everything's very prescriptive, to when they go to college or graduate school, when all of a sudden they have to be more independent. So the symptoms can emerge later in life. Great, it would be helpful if we could get testing, but we can't. So I'm just going to talk about a couple of tools real quick that can be done either in the office or with the patient's participation. These are both self-reports, because I'm aware of your environment, that might give us shed some more light on things. I'm going to click on the first tab, which is for the DES, and you're probably familiar with it. I think psychologists do more with this than psychiatrists do. The Dissociative Experiences Scale is a 28-item questionnaire that asks about experiences of daily living that can be congruent with dissociative identity disorder, everything from just your fugue states to full-on dissociation. And if you look down this, the way that it's scored, this is a PDF that if you actually download it from the web, this version of it, which I think is from the UK, allows the person to put in a percentage, and then it tabulates towards the end. So it's like I forget the name for it, like a functional interactive PDF. So some people have the experience of driving a car and suddenly realizing that they don't remember what has happened during all or part of the trip. And then you select a percentage, and this scrolls on down to asking about things like finding clothes in my closet that I didn't buy, having conversations with people that I don't remember. There are 4 pages to this. Again, 28 items. I would just administer it to see where she pans out. It could be that she's got a low dissociation rate and you could move on, especially if there's no trauma history. But I think it would just be interesting to see if some of these other items, if she would endorse them, because it might have a slightly different indication in terms of treatment than if it's just pure ADHD.
Okay.
The other item is the Winder Utah, which I think we've also discussed before. This is probably the standard, although it's not the best tool, it's one of the better ones for diagnosing adult ADHD. It relies heavily on having some working memory of one's childhood, so it doesn't work for everyone, but it asks some of the questions about being restless, fidgety, afraid of things, easily distracted, worrying. So one component is to have the patient fill out, and this again has multiple pages. Other parts of it require that you have a parent, if they're available, fill it out. But this, again, is scored, and there's a more complicated scoring that some items are weighted more heavily than others, but you look to see if they've had these types of outbursts from an early age. Now, if it turns out that she screened heavily positive on the Winder, and again, both of these scales are not proprietary, you can download them, or proprietary, you can download them from the internet easily, and find out where she lands. If she lands very high, then I'm thinking, gosh, she probably needs a stimulant, probably needs to go to a community mental health center. On the other hand, if, say, her DES score is moderate, she doesn't score really high there, she doesn't score super high on the Winder, if I were to address her anxiety alone, I'd probably go with an SSRI. I would likely pick one of the more activating ones just because she's already got some trouble with fatigue. Probably fluoxetine or sertraline would be the two, but at a very low dose. Typically speaking, when you're treating anxiety, you want to go maybe half speed of what you would typically start at for depression, because a lot of times that initial serotonergic charge will make people a bit worse. I know I've spouted off a lot. Let me pause and see if you have any questions or feedback about what I've recommended.
Those were great. You know, I have not seen the DES since I was in graduate school. And I remember giving it to a patient who answered 0% on everything except the one where it says, some people report that they have this, they notice voices in their mind, and tell me how often this happens for you, and the patient put 80%. I was like, okay, what have I got here? That's like a really narrow form of schizophrenia. And when I queried, the patient said, well, yeah, I know it's supposed to be 100%, and I really feel bad that it's only 80%. I said, what? And she said, wait, voices in your head, it's like your conscience, you know, the memories of what people tell you that you're supposed to be doing, the right way to live. And I try to do that all the time, but there's times when I fail. So even with this DES, you still have to query. A good clinical interview has to supplement it. I just, it was funny that I got that response. I'm also laughing because I would probably answer 60% to questions 1 and 2 right now.
Yeah,
home. So, but you know, these are going to be really helpful with her, I think, and I think she will feel like progress is happening. At the third session, she said, I almost didn't come today because I usually drop out by the third session if talk therapy isn't working.
That's good for you.
And that she would drop out by session number 3 if talk therapy doesn't work is an indicator to me of how impatient she is with things.
Most of a lot of patients just drop out after one. So that's
they drop out after
one.
one.
In general.
But yeah.
Okay, can I ask you something, Dr. Bonds? This Wender scale, I saw what you put in there, and it was all questions about childhood. Is this the whole thing, or is there another page about in your adult, or is it, who is this for, this questionnaire?
This is for adults, but attention deficit by definition has to happen in childhood or very early adulthood. And typically it's not something that you develop, say, at the tender age of 35. It happens before the neuronal synapses are all solidified. So for most people, you think about childhood going into maybe their college years or their early college years. So probably 0 to 18. And if they didn't have it before then, it's unlikely to be attention deficit hyperactivity.
So this says 61 questions. That must just be the first page or something.
Yeah, this is only the first page. I think if you were to look at it on the web, but the second page honestly is not that different. I just looked at it again today freshly. I think the other section is for parents to complete, and again it does reference mostly childhood. It is one of the limitations. I mean, there are more elaborate scales for both of these diagnoses that you can administer, but you kind of move into the more like, this is going to take me an hour to an hour 45 minutes. And I know that in primary care settings, you just don't have that time. This is something that between appointments or while someone's waiting in the room for you, you could have them complete this to the best of their ability or bring it back at next appointment time. And so these are sort of quick and dirty screens, I would say, but they're by no means thought to be, as Dr. Johnson mentioned, to take the place of a solid clinical interview. But in this particular lady, some of the complaints that she had just aren't the things that I typically hear from someone with just solid ADHD. It's more about focusing on attention and being able to be organized and cluttered. Her reports about some of the multiple voices and all that, that seems to me like it might fall into a different category.
I think I need to clarify that because she didn't indicate that they were necessarily different voices or voices separate from herself calling her name. It felt in her description that it was more integrated than like that. It was like a part of me is saying, whoops, I need to worry about this, and then another part of me jumps in and says, wait, but you're forgetting about that, and then another part of me says, hey, did you lock the front door? Did you remember to drop your kid off at preschool? So this competing, distracting sort of zipping around in her mind. But I want to inquire further because of the way, like you said, the way in which she phrased it.
Yeah, it was a little odd. So any other questions about her before we go on? I know that I wanted to get to Dr. or Monica Ellis's case. Dr. Ellis, are you still there with us?
We're great, thanks.
Type it in. Okay, good. So I'm going to attempt to read because I think that Monica's challenged with her audio. So I'm going to scooch forward. I'm not trying to kiss anyone. Not that I don't love you all, but as far as her case, she has a patient with well-controlled HIV, and this is a follow-up our discussion last time about cannabis in the brain. Currently, he's prescribed a triplet, and he has no other health conditions of concern. The patient uses cigarette smoking to cope with his stress, and previously smoked 1.5 packs a day, but recently, over the past few weeks, has been able to decrease his use down to 9 cigarettes per day using nicotine-bound and supportive coaching from the 1-800-NO-BUTS program. Way to go. In our treatment, we have worked with him on coping skills training as well. The problem is that he has substituted cigarette smoking with initiation of cannabis smoking. We've already discussed the harm of cannabis related to HIV health and generally. Insofar as motivational interviewing, patient sees zero harm in smoking weed. What other ways can I help him understand the harms and decrease cannabis smoking? That's a great one. There's a resource, I'm not sure if I distributed it last time, but it was from, I think it's the group at University of Pittsburgh about cannabis in general. I think it's Western Psych, to talk about some of the cognitive things that are going to happen if he's using, for example, the slowed reflexes, the inability to cope with complex data sets and information, decision-making, I think you really just let people know that over time, this drug kind of dumps you down. And I think you probably are well equipped to talk about some of the health risks. Doesn't sound like he's immunocompromised specifically. There are things that one sort of sees the body with when you smoke cannabis, if he's using it, that put him at risk for things. I think the big one that would come up when I worked with folks was heart transplant patients getting immunocompromised from fungus, and to know that, gee, you're seeding your lungs with these potential pathogens that would, in the event of your getting ill, make your recovery much more complicated. I can't recall the name of the specific fungus, but I do know that there were some that people were at greater risk for. If there's a medicine person on the line, help me out here. But I think that that's kind of the best you can do. And unfortunately, people are going to probably find this medicine really helpful for them. It helps them to relax. They have a lot of reasons to do it. And then I move into the mode of more harm reduction to say, how do you think you could reduce your use? Is it possible that you could use a vaporizer instead of smoking it, because then that's less toxic to the lungs, because then they're getting more pure THC as opposed to all the other, I guess you'd call them carcinogens that come from smoking. So I don't have a great answer except we're focusing on some of the cognitive limitations that are coming about as a result of using, and the fact that it basically helps people relax, but it kills their motivation to do anything. So if he has any goals in life and he's not achieving them, to focus on, well, this may be one of the reasons, because it tends to kill one's motivation and drive. I don't know if that helps address concerns that you had, or if there are other specific things. And if I didn't already, I'll try to send to Karen that reference, because I've seen it as a PDF on the web, so I'll get it out to everyone. So we were slated to possibly talk about my experiences in Africa, which fade by the day, but I'm still able to do it perhaps next time. And I'm going to thank you all for joining us and hand it back over to Karen to close us out.
Okay, thank you. We have 1 minute. A few of you had a problem signing on. I do need to know quickly if you could describe to me what that problem is. I think that WebEx has upgraded their system, and also my new computer is 8.1 Windows, and it's not compatible with WebEx. They're working on it. It may take them a month. So I have no idea what really was happening when you clicked on that link, if it had anything to do with their upgrade. Can someone describe to me the problem?
I think it was Allison. They just got a message that page could not be found.
Okay, page could not be
I'm
found.
sorry. Were you asking me if there was to describe the problem?
Yes, just describe it, because I'm going to call WebEx as soon as we get off.
Okay. I clicked on the link that was in your website, and the my internet browser came on, and it ground and ground and ground for a long time, and then it said, this web page cannot be displayed. Okay. Do you want to troubleshoot problems? It didn't have anything from WebEx on there. It just said the page cannot be displayed.
Okay. Well, that's helpful. All right, and I'll tell them what I did on my end, and then I know what your response was. I guess Monica Ellis also had that same problem? Yeah, Monica wrote in, cannot load page. Okay. Okay, all right. Well, hopefully we'll figure it out, and so the next time this won't happen. I hate when any system doesn't upload or an upgrade or whatever they do, because it messes up the way you work. Yeah. Okay, thanks so much. And the next session is June 25th. Hopefully we will have that session. Dr. Bonds is being very challenged right now with some staffing issues, and his time is at a high premium. So we're hoping, and we're also still looking for funding. We're getting a little closer day by day. So those are really the only announcements. We hope to see you next time. I'll let you know what's happening in between, and keep those cases coming. Thanks so much.
Okay.
Bye.
Bye.
Okay.